Okay, so when we're thinking about Eric and all the pieces that we're going to put together, right, we're going to come back to our sins. So what's his severity? He's pretty low on severity as far as his hip goes. So if you look, he's 2 on average. Maybe it spikes to a 5, but that probably is in conjunction with either like a bunch of overactivity or a long period of time of sitting. Low back is a little bit higher on the list of severity, so we might start to get from mild to moderate. And then his ankle is probably one of the bigger contributors to his whole right-sided kinetic chain. If we just stay on his hip though, so we're moderate in severity, irritability is actually pretty low. He likes movement. We know we need to stretch him. We need to do some manual work on him. So we're gonna be able to do a lot with someone that presents like Eric and really get some of that good nutrition to the joint and to the musculature around that area. When we think about nature, we're not really thinking inflammatory. We're thinking more musculoskeletal, especially because he tells you that it's with prolonged static postures that really start to bother him. As we get into movement and those kinds of things, we're going to start to work on some of the mechanical error that might be happening from his lower kinetic chain all the way up. Which if we dive a little bit deeper into his history, we'll probably find out a little bit more correlation between those ankle sprains, now up into his right hip, then into his right low back. If we think about stage, we're pretty consistent. He's staying the same. It's not really getting better. It's not really getting worse. It's just kind of staying the same over the last several years. But he also hasn't done a lot to address it or to change his scenario. So when it comes to therapy, that's something that we'll talk about is consistent adherence to a home exercise program that would really help him. When we think about stability, same thing. We're not really worried. He's not spiking high, spiking low, that kind of thing. Probably a little bit more when we think about that as we talk about low back and his ankle, but as far as his hip goes, we're pretty okay with everything. He has no systemic pathology, so we would have cleared that on our medical history form. When we start to get into our differential diagnosis, he doesn't fit into this like neat bucket, right? So if we think about femoral acetabular impingement, telltale sign is that they're getting pinching at the deep end of their squat. Still not gonna rule that out yet though for him. I do think he's got impingement that's happening, but it might just not be the traditional, what we think about as that cam pincer type of relationship. And again, just a more of a mechanical error that's happening. He also in his squat, if we look at him, maybe he's shifting away where he's opening up that joint and not really actually getting into where he's impinging on the acetabulum as the femoral head is coming into that. Hip OA, what did you guys think? Yeah, maybe some of those like morning signs, morning stiffness. There are some of the characteristics, but really he doesn't have the age presentation. And I would also wonder what his gait looks like in the morning and if his ankle is really the stiff part and then it kind of cascades up into the rest of his body rather than he has some OA. But when we look at him on the table, what are we really looking for if someone has hip OA? We're looking for multi-directional limitations, right? So they would be limited in 3 planes of motion or more. So we'll take a look at and to see what that looks like for him. Hip flexor pathology. Kept pointing to this hip flexor, but then he kept coming down into where the adductor inserts, kind of that C sign a little bit. So we just can't, we want to know that there's probably some hip flexor involvement into this scenario, but maybe it's not necessarily like a snapping hip type of syndrome. We should have asked if there was snapping, but usually if that's gonna happen, someone would have presented like that and told you, oh, every time I do this, it snaps over as I move my leg. So that really went pretty low for me on my differential diagnosis. Greater trochanteric pain syndrome. I didn't ask much about lateral pain. He didn't tell us, but he did kind of tell us that whole wraparound, which we talked about in class. Can have some of that as we get into that greater trochanteric pain syndrome, or it can be high up from the lumbar spine referring into there. So we really have to do a thorough exam of the lumbar spine, make sure that he's not getting some radiating pathology into that right front of his hip. But we're still gonna come back to that. We think it's probably this mechanical nature where he's got a lot of shortening on that right side, so he doesn't have a lot of hip mobility like he should because of the tension relationship of the musculature and the tissue surrounding those areas. All right, hopefully you guys followed along with that and that's what you wrote down. And now we'll get into our objective exam.